Hello, everyone. Hope that everyone is joining. I see people trickling in. Welcome to this TBPPM webinar. I'm really happy to see everyone joining. It's our Friday webinar, and we are also live streaming at the same time. So I'm turning on the live stream. This meeting is being recorded, and we have a wonderful panel for you today. So for those of you who don't know me, I think everyone knows me. My name is Petra Heidkamp. I'm the community manager of the TBPPM Learning Network. I'm really happy to see you all joining today. We are also, this is a 75-minute session, and we have excellent speakers today talking about evidence of success within for engaging private providers. And we also have the photo contest winners announced today. So we're looking forward to sharing with you. Please use the Q&A for any questions. We are asking our panel members to kindly also answer in the Q&A box, and the Q&A is easier than the chat, so please do that in the chat. You can say hello and introduce yourself. We'd love to hear from you. Also, feel free to turn on any subtitles if you need to. That is possible. And we're live streaming on YouTube. I will share the link to the YouTube in the chat in a minute. And you will be able to receive a report, all the presentations, everything will be online for you to look at afterwards if you missed this. So thanks for those who are listening into the recording. We know that you are there with us too. We will be posting also on LinkedIn and Blue Sky and Twitter, and so you can follow along with the live stream. Please join the Learning Network if you haven't already. And for today, we have a great moderator that I'm really pleased to introduce, my friend and colleague, Dr. Vijayashree Yellappa. She's a medical doctor specialized in public health and has a fellowship in HIV medicine. She is right now, she also has a PhD that is focused specifically on private provider engagement within India, and she's currently working as the senior TB consultant at KNCV. We've worked closely together as the founding chair for the TBPPM in India over the last many years, and I'm very happy to lean on her expertise today to guide us through this webinar. And so please put the most difficult questions in front of her, because she will make sure that our panel will take them up. So thank you so much, and Sri, I'm handing over to you. You're still muted, Sri.
Thank you so much, Petra. It's always a delight to be working with you and host this webinar series. Nice to see our colleagues and friends as panelists. So as we know, TB remains one of the world's deadliest infectious disease, claiming over 1 million lives each year. Despite being preventable and curable, TB continues to thrive, particularly in high-burden TB countries where significant proportion of people first seek care in the private sector. This is where the relevance of PPM becomes not just important, but absolutely critical in our efforts to eliminate TB. So PPM is not only a strategy, but it's a paradigm shift in how we look at TB care. PPM recognizes that to truly eliminate TB, we must engage all care providers. It is public, private, formal, informal providers. Essentially, we need to go where the patient goes. We have come a long way in the PPM strategy and approach. There have been various guidelines issued by WHO. And several countries have demonstrated several models which are feasible, and they were demonstrated the cost effectiveness and efficiency in eliminating TB. Today's webinar is about showcasing what works with real-world examples where PPM has moved the needle of TB outcomes. I'm very glad to have our panelists who will bring us the most feasible and the most effective models that they have been implementing or supporting. Let's get started. I hand over the floor to Monica. Monica is from Global TB Program. She leads the work of multisectoral engagement and accountability, including engaging sectors beyond health to address the key drivers for TB epidemic. She is heavily engaged in strengthening the public-private sector partnerships. Her scope of work includes development of innovative policies and strategies on TB elimination and public-private mix and high-level advocacy and knowledge sharing. We are very glad to have you today, Monica. Over to you.
Thanks so much for the very nice introduction, Shri. It's really a privilege to join you all here, both my co-speakers, and thanks to Petra and the PPM Learning Network as well. So let me dive right in. So the focus of my presentation is going to be on bridging the gap and how PPM can help reach the missing millions. Now, before I start, let me just ask Petra or Shri if it's visible.
It was visible.
Okay.
Yeah.
It was, and then now it's gone. Hold on. Does this work now? Full screen?
Yeah.
Okay, brilliant. So as I said, what we'll talk about is public-private mix as one of the key solutions to reach the missing millions who still miss out on access to life-saving TB prevention and care services. So let's dive in. Now, Shri has already touched upon, but just to remind you, some of the data, TB remains the world's top infectious killer. The burden is still quite heavy, 10.8 million people falling ill, close to 500,000 people with drug-resistant TB. And also the issue of infection, which actually in the PPM space, we haven't really gone into. But again, just to remind everyone that this, of course, remains also a challenge that should be addressed if you're looking at ending TB. Now, the crux of the problem is that 2.7 million people miss out on access to TB care, and this is data from our Global TB report. Now, the good news, of course, is that if you look at the notifications, it's been steadily increasing, and you can see the rise other than the dip from due to COVID in between 2020 and 2021. But then if you look at the increase that you see in 2019 and then what was picked up in 2023, a lot of this increase in notifications actually came from PPM or public-private mix collaboration-led efforts. So in that sense, yes, a lot is being done, but a lot more still remains to be done. The same with drug-resistant TB. We know that around 400,000 people fall ill with drug-resistant TB, but only 1 in 3 actually access care. And you can see this huge gap in detection and enrollment on treatment. And we know that one of the major reasons, again, for this gap is also that we're not able to reach them, and public-private mix is the answer here as well. The same when you look at childhood TB. Of the 1.2 million approximately kids and adolescents who fall ill with TB, nearly 50% miss out on access to care. We know, you and I know, that many of them will first access care through pediatricians or, other providers who are not really linked to the national program. This could be either in the private sector or unengaged public sector care providers. So when you're looking at reaching the missing kids and adolescents who miss out on access to care, PPM is also a solution. Same with, if you look again at, just to remind you, world leaders made commitments in the UN high-level meeting political declaration in 2023. You look at this, right? Reaching 45 million people with treatment, TB treatment, 45 million people with TB preventive treatment, 100% access to rapid WHO-recommended rapid tests, social protection, and all the rest. But if you look at those top 4 targets, again, private sector plays a massive role. We know that the reason rapid test coverage hasn't really spread is that a lot of the providers, especially in the private sector, still don't have access to these. So it's a question of also closing that gap. And as I said, if you look at other commitments on children, on drug-resistant TB, or on looking at the pandemic preparedness agenda, the humanitarian crisis agenda, again, private sector plays a big role. And this is where the whole notion of multi-sectoral engagement and accountability, which is a priority. And when you're looking at the TB response with all of its drivers and determinants, you cannot look at it without a multi-sectoral view. And this is where this comes into play. And this is why in WHO's multi-sectoral accountability framework on TB as well, we do have this very explicitly mentioned, talking about links with different sectors as well as the private sector. So as, I mean, all of you know, if you're looking at the Sustainable Development Goals, the NTB strategy, or any of our strategies, the ultimate goal is to get universal health coverage. And this, to get there, again, it's all about PPM. We know private providers in many settings are the first point of care. We know they're not fully engaged, unfortunately, in the TB response. There are several barriers in place, such as inequity, stigma, discrimination, the various drivers. All of this leads to people first accessing care in the private sector. And if we do want to reach UHC again, we need to make sure that we have all the providers engaged. And this has been a strategy for WHO. Now, the good news somewhat is that we have been advancing, especially in our big 7 PPM priority countries, where you see very clearly that thanks to all of the efforts that have been done over the past few decades in collaboration with all of us, right? WHO, the various partners like Stop TB, we have Tawfiq here, we have KNCV, we have with Shri, we have our PPM Learning Network, we have all of the countries advancing PPM, and there has been a significant boost, especially, I would say, at 2 points. One was when the Global Fund started infusing a lot through their catalytic initiative. There was really this focus to up the game on PPM. That was a turning point. Another turning point was since 2018, there's been this high level prioritization with world leaders really pushing the ball and saying, okay, we need to close gaps, we need to advance care. And that has led to this push where people see PPM as a low-hanging fruit. And so you see, especially in the big 7 countries, that there has been a scale-up in public-private mix contributions. Now, just to remind you all, this is just a very quick slide to tell you that PPM, when I say PPM, it's private sector engagement, which is the key priority, but also looking at unengaged care providers who are not directly linked to national programs and thus not notifying people with TB. So based on all of this, in 2018, with key partners, we launched the PPM roadmap. This was spearheaded by our PPM working group, WHO, Global Fund, of course, then USAID, Stop TB, PATH, and others. This was really, again, a very powerful tool to drive action on PPM. And we now have a 2024 edition, which 2025 now, which will be updated, where we have 10 key priorities, which range from building understanding about patient preferences, setting appropriately ambitious targets, getting the political momentum, harnessing digital technologies, leveraging the power of different partners, delivering range of financial incentives, having regulatory frameworks in place, and importantly, monitoring progress and building accountability. This has been key to really roll it out across countries in collaboration with efforts such as national strategic planning or or even through the roadmap on advancing, on addressing TB in children and adolescents. And as I said before, this is one of the key sort of priorities. PPM is quite critical and it's featured in the multi-sectoral accountability framework. And as part of this, we at WHO, with the support of the Gates Foundation, developed enhanced data dashboards for the big 7 PPM priorities. And this was really critical to improve visibility into PPM performance and commitment, increase accountability, and strengthen TB programs. You know, there's a saying, what's measured gets done. So if you're talking about public-private mix, then it's really critical that you're measuring it. And this is also important for advocacy purposes to raise resources for it. So just to give you some backdrop into the whole process, we started it in late 21, but there has been this whole process that we worked hand in hand with the 7 country national programs, key stakeholders on the ground, with the support at the global level of the PPM working group, partners, key experts. It was supported through country missions, several consensus meetings, local consultants to support. And with all of this, we came up with a very strong prototype for a dashboard. So we got all countries together and we said, okay, we want to go beyond just measuring PPM notifications. We wanted to go beyond to see PPM across the whole continuum of care. How many people are being treated in the private sector? How many people are accessing TPT or TB preventive treatment in the private sector? How many are accessing WHO recommended rapid tests in the private sector? All of this has been a gray area. And we know that countries have this data, but it wasn't being systematically measured, shared, and built upon as a resource. And based on all of this, we basically developed visualizations. We have a PPM webpage. I'll post the links after my presentation. It's also part of the World Health Data Hub that WHO hosts here. And we developed a policy brief that was released last year at our PPM working group meeting in Dhaka. Now, looking at this, you can see here is just like a very quick glimpse. We looked really at the indicators. We looked at disaggregation, looking at provider coverage, looking at surveillance of people with presumptive TB, notifications, bacteriological confirmation. As I said, it's really important to know about WHO recommended tests, rapid tests, if it's being taken up or not. So we put this sort of minimum set of indicators as part of the prototype. And an important element was to look at ownership, disaggregate by that. So there was public for-profit, private not-for-profit, unengaged sector, and also looking at it from primary, secondary, and tertiary level. This was really important to really disaggregate and unpack where people are accessing care so that you can target interventions. Now, this was not a very easy exercise. It may look very easy in this presentation, but it was extremely complicated because you're talking about a diverse set of countries. So in practice, everybody agreed on what the prototype would look like, but actually getting consensus on the typology, making sure everyone has the capacity, the digital capacity, for instance, case-based monitoring was critical, all of that. So you can see here the status of, some countries could report on practically everything. A good case in point was Indonesia, which had all of the data. Other countries, had to build up the capacity, had to pull out data, encourage countries to report. The Master Health Facility List, that's what MHFL stands for. This was also found to be very critical, and the importance of linking it to the country surveillance system. And of course, in some settings where digitalization of data hasn't happened yet, manual data analysis takes time. And for us, the most difficult thing was getting approvals. We have the whole dashboard of data, but getting the highest level approval for these was quite a challenge. Now here, very quickly to show you that, we do have, as I said, on our website, a dashboard webpage. We have interactive visualizations. And of course, as I said, it's present in the WHO World Health Data Hub, where you can see, by ownership and also contribution to treatment, to notifications, to care. And this very quickly is, based on all of this effort to develop the dashboards, we put out a policy brief that's now being used by several countries to look at basically setting up dashboards. So looking beyond the big seven, right? So looking at, we listed what are the steps. Undertake a review of the surveillance system in both sectors, make sure there are policy regulatory frameworks to create an enabling environment for monitoring as well, ensuring effective planning for PPM monitoring and accountability in national strategic plans. And the important step was getting all key stakeholders right from the beginning in the development and implementation of the dashboard, and of course, promoting the efforts on multi-sectoral engagement and accountability. As I said, after my presentation, I'll post links to all of these. So as I close, I just have this one final slide. Now, you all know that it is a very challenging landscape for global health today. As WHO reported last week, over 27 countries are already impacted, and essential TB services, including procurement of drugs, cartridges, other consumables, have been disrupted. We cannot look at this. It's kind of going back to what we saw a bit during the COVID pandemic, where essential TB services were severely disrupted. We're seeing this happen again. And like at that point, we know that the focus of NTPs will inevitably shift, and rightly so, because they're looking at, okay, getting the drugs to the people in need, getting the rapid tests in place. All of this is, of course, essential, and of course, PPM is essential as well. Now, what is essential for us on our end is to really promote that the private sector is actually a key partner and can help offset some of the load. And this is where it's important that PPM is not lost. We've had this prioritization of PPM. We need to make sure that it continues, and private sector is seen as an essential partner rather than a barrier. So this is something we need to highlight. Also, we have Shree is a co-chair. She's from KNCV. The chair of the PPM working group is Global Fund, Mohammed Yassin, which is also excellent. And we hope that the Global Fund support continues for countries, and that we are able to have the right PPM actions and indicators well featured, so that there is support, at least some support for PPM, which is continued. We are already seeing a lot of requests for support on the use of the data dashboards. We hope that this is something that is also expanded and extended beyond the big seven countries, and we are standing by to support. As I said, there's a huge agenda. We know, for instance, that there is this push towards access to new and improved diagnostic and treatment tools. We need to make sure not just the public sector, but also the private sector has access to this, so that no matter where a person with TB goes to access care, they are able to access high quality, the right quality care. And then, of course, leveraging the use of digital technologies. And when we talk about social protection, make sure this also encompasses private sector access, so that people with TB don't face catastrophic costs. And through the learning network, and of course through our working group, we will continue to promote positive examples, but we urge you also to join us in supporting this effort to keep putting a spotlight on PPM as one of the key solutions when you're looking at ending TB. So we need all hands on deck to end TB. Thank you very much.
Thank you, Monica, for this excellent presentation, and again highlighting how PPM we need to prioritize. I have one question. I understand that we need to go beyond the mere case notification, but close the gap in terms of DR-TB and childhood TB. And also you talked about multi-sectoral accountability, where we need to go beyond the health sector. And you did mention about the 10 key priorities. All this requires an investment. So do you have any advice on how do we keep TBPPM high on the agenda, where we could integrate private sector engagement within the national strategic plan?
So I think, Shree, this is a very important point, and this is something I think that we're already trying to do. One, of course, avenue, as I said on my last slide, is having the support from the Global Fund. This continues to be very important because, a lot, especially when you're looking at low and middle income countries with a high burden, the dependence on international financing still remains high. So it's important that, and all of us as agencies and as people working on TB need to ensure that national strategic plans do include a strong component on PPM. So this is something that we are advocating for and promoting. It's part of a national strategic planning guidelines, for instance. We know that Mohammed also, of course, as from the Global Fund, our chair is also, of course, making sure prioritization is kept on this. And so there's, of course, this sort of advocacy. On the domestic level, again, we've come a long way to do this sort of mind shift change. And I think some of you may remember that at one point, there was absolutely no trust between public sector and private sector. Both sides couldn't work together. But we've seen now that there's been this drastic mind shift building on the positive experiences that we've seen over the past 5 years. So it's really important, and that's why forums such as this run by the PPM Learning Network, we need to keep, highlighting the positives. In this difficult landscape, we need to keep highlighting that, the private sector can play a strong role, whether it is in domestic financing, offsetting the cost to health systems. One of the answers is private sector. They can help. So, identifying new innovative solutions with PPM in the mix. So this is going to be really critical in this new landscape.
Thank you, Monica. This is such a strong advocacy and we really appreciate. Now, coming over to Taufik from Stop TB Partnership. With over 15 years of dedication to combating tuberculosis, Taufik has spearheaded numerous research and implementation projects, mostly focused on active case finding strategies in diverse settings. He has been also instrumental in pioneering TB preventive treatment rollout nationwide and setting up external quality assurance for GeneXpert. Over to you, Taufik.
Thank you, Sri, for the introduction. And good afternoon from my end. Let me share the screen. Is it visible in full screen, Sri?
Yes, Taufik, please go ahead. We can see the screen.
Okay, thank you. So good afternoon, everyone, again. And today I will be sharing on behalf of all the co-authors our recently published manuscript and the key findings on the engaging private providers to increase the tuberculosis detection and notification. And this experience is evidence from the 35 TB supported projects. So as both the speakers already highlighted that private providers are often the first contact point for individuals with TB symptoms. However, many of these individuals who are treated at the private sector are not reported on time. And in 2023, we have seen that around about 8.2 million of the people who developed TB were notified out of the estimated 10.8 million people. So we missed around 24% of the individuals who actually developed TB during that period. And engaging private providers is critical to close this notification gap and also ensuring the timely diagnosis and treatment. So just to introduce TB Reach, who are new to this platform. So TB Reach is a grant-making platform to improve TB detection. It received its foundational support from the Global Affairs Canada, but is supported by multiple donors. And we at TB Reach provide catalytic funding through a competitive calls. And TB Reach supports the innovative approaches like the private provider engagement and also technologies to find and treat people with TB and also with TB infection, and also with support implementing new tools like new diagnostics whenever they popped up. And TB Reach emphasizes rigorous monitoring and evaluation and aims to document experience and link the impactful interventions to a long-term sustainable funding. So just to give you an overview of the projects that we worked on the public provider engagement, from December 2019 to March 2022, over 35 projects through 4 different funding waves of TB Reach, which was supported by USAID, implemented private provider engagement projects in 19 countries. Over half of these was from Asia and followed by Africa and Central Asia. And these projects tested a diverse private provider engagement approaches, and that created a great platform for cross-country learning sharing. So all the projects reported quarterly through the TB Reach grant management system, and we tracked the TB diagnostic cascade indicators along with the National TB Control Program notification data. And we compared that with the historical baseline and control areas. And the private provider engagement specific M&E framework added provider level metrics like mapping, engagement, and referrals from these private providers. And these projects engaged a variety of private providers, which included informal private providers such as the traditional healers, unqualified medical practitioners, pharmacies, drug sellers, private formal providers like general practitioners, specialists, and also private formal facilities that included private hospitals, multi-provider clinics, and also the private laboratories where the diagnostic evaluation happened. And we considered the private provider engaged when they formally had an agreement with the projects to participate in the TB intervention implemented by the projects. And we considered them active when at least one individual with TB symptoms was reported or referred by these private providers during that quarterly reporting period. And this slide actually summarizes the private provider engagement metrics along with the TB cascade of care indicators. And it all started with mapping the private providers in the intervention areas. And then these private providers were engaged formally through some sort of training or formal agreement. And then individuals visiting these private providers were then screened. And whenever the private providers identified any individual with TB symptoms, they were marked as a presumptive TB patient. And then they were referred to the diagnostic centers or diagnostic facilities or public facilities for different diagnostic evaluation by these private providers. And among these engaged private providers who referred those individuals were considered active. And once tested, individuals with confirmed diagnosis were then linked to treatment at government and sometimes in private facilities. So just to remember few data points going forward, project yield was considered as the total number of people who were diagnosed with TB directly through these private provider engagement interventions. Private provider engagement notifications was only those diagnosed individuals with TB who were notified to National TB Control Program and also linked to treatment. And we assessed additional notifications by comparing the TB notification in the intervention areas before and during the project period. And we considered private provider engagement contribution as the proportion of the total TB notification in that evaluation area that directly comes from this private provider intervention. And along with other key metrics that we considered number needed to screen and number needed to test to identify one individual with TB. And to estimate the cost per person diagnosed and started on treatment, we considered the project expenditures, including the staffing, transport, diagnostics, monitoring and evaluation cost by the project, and also the administrative cost. So moving into the results, these 35 projects screened around 13 million people over time, identifying around 385,000 individuals as presumptive TB, and those were referred for diagnostic evaluation. And around 332,000 plus individuals were then evaluated through different tests for tuberculosis, identifying 64,000 plus individuals with active TB. And around 97% of those individuals with TB were then linked to care. So we found that around 281 people were needed to screen, and around 7 people were needed to test to find one individual with TB. So as I mentioned, around 63,000 people with TB were successfully linked to treatment and notified to the National TB Control Program through these projects during the engagement period. And overall, there was an increase of 25%, or 61,000 people were identified as additional TB patients from the baseline during the intervention period. And on an average, 20% of all these notification in that area was directly coming from the private provider engagement projects. And the median cost for diagnosing one individual and putting them on treatment was USD 481, which was ranging between USD 23 to around 8,500. So this slide is actually to give you a quick visual sense of the wide variation across the projects. You can see that each dot here represents a project, and then the number of TB patients started on treatment was plotted against the cost per patient for treatment. And you can see that some projects with a lower cost achieved high volume or high number of TB patients, whereas the other projects operated at a higher cost to identify and put one individual on treatment. This also highlights the variation or diversity in the operational models, the private provider engagement models as well, and sometimes the level of maturity among the implementers and how that changed over the period across 4 different waves of TB-REACH funding. From wave 7 onwards, around 25 projects track the private provider engagement more comprehensively. So during the baseline period, these 25 projects mapped around 69,000 private providers in their intervention areas. And 75% of those providers are actually informal providers consisting of private pharmacies, drug stores, and also some other informal private providers. And the remaining 25% was private formal providers or private formal facilities or private laboratories. And during that baseline period, which means before the TB-REACH intervention, only 2% of these providers were engaged with TB intervention or directly notifying TB patients, which they did like around 9,500 individuals were notified from these engaged 1,200 private providers during the baseline period or the TB-REACH intervention. So when these projects started engaging these private providers actively, out of those 69,000 mapped, around 31%, which is like 21,000 private providers was engaged. And it also represents the similar proportion, like 75% of the engaged providers were informal, like private pharmacies or drug sellers or informal private providers. And remaining 25% of the engaged providers were formal, general practitioners, laboratories, or formal facilities. And out of these engaged providers, over the period of the project, 58% of those remained active, which means they referred at least one presumptive
Topic.
with TB. Yes,
Sorry
yes, please.
to interrupt.
Yes.
We have 2 minutes to conclude the presentation.
Okay, sure.
Thank you.
So they 58% of the private providers remain engaged, which means that they refer at least one individual with TB. So over the period, they notified or referred around 300,000 presumptive TB individuals for diagnostic evaluation, which on average, each private providers referred at least 25 individuals with presumptive TB, ranging between 5 to 171. And of those referred, 85% got tested, and finally, over 54,000 TB patients were diagnosed and notified from these private providers. Just to conclude, that TB Reach experience showed that the structured private provider engagement can effectively improve the TB detection and linkage to care. And tailoring these interventions or engagement approaches to local context while considering the provider types, care-seeking behavior, and in-country regulations are key. No one size fits all. So sometimes you need to prioritize the high-yield provider types that can improve the impact. We need private provider engagement, a specific M&E framework that can guide us on real time. And finally, engaging the diverse providers, expanding that to informal providers can expand the reach and can reach the underserved patients. Thank you, and happy to answer questions during the discussion section. Over to you, Sri.
Thank you, Tawfiq. Excellent presentation. I'm sure this is a massive effort to gather all the TB Reach funded projects and do this kind of analysis. Congratulations on that. So we have one question on use of digital health technology, especially considering so much revolutions happening recently. Could you comment on, were there any use of AI or digital applications to assist the private providers in terms of recording or reporting or even incentive payments? Over to you.
Thank you, Sri. Very good question. So different projects use different digital technologies while implementing the projects, starting from mapping as well as the screening process of the individuals coming through the private sector. Many of the projects use the digital screening tool implemented either through an app that was hosted by a mobile phone or tab, and also to prioritize or identify the individuals or private providers where the higher yield was coming from. They used different digital tools to answer those or identify those individuals. And some of the projects also used like artificial intelligence enabled x-rays in some of the facilities to attract both the private providers as well as the clients coming to the private facilities.
Thank you. You have another question, maybe you can take this up in the chat. This is about how to engage the informal providers, what kind of approaches were used. I will move on to the next presenter. Thank you, Tawfiq. I call upon the next presenter, Kinz Ul Eman. She leads the Dopasi Foundation from Pakistan. It is a non-profit organization that aims to empower people affected by tuberculosis and also promote a human rights-based approach to TB response. Kinz holds a Master's of Science in Development Studies from the University of London and a Master's of Global Health from the University of Milan. Over to you, Kinz.
Hi, Shri. Thanks for the introductions and really nice to see you all. Thank you to the PPM Learning Network for putting this webinar together. So we have heard from Monica on the whole landscape, and then Tawfiq has given a broader picture of multiple countries. I will be speaking from a country perspective of what have we done in terms of engaging and tapping private sector, potentially beyond the conventional sectors that have historically been tapped, and some insights on the way forward that we assume, especially given the current funding landscape that we have all been listening about. So by WHO definition, engaging all providers through PPM approach is essential. And we have heard about the detail and the work that has been going on the advocacy level from Monica, so I'll not get into the details of this. In terms of Pakistan, we have over like nearly 700,000, we can say, people affected by TB, and we still keep on historically missing around 30%, and the private sector at the moment is contributing to 43% of the TB case notification. This is the TB case notification. We see a dip during the COVID times, but then we have been able to cope up. As mentioned earlier as well, even in Pakistan, we see that the preferred choice, at least for the first care, for accessing to care, has been the private sector, with approximately over 80% of people preferring going to the private sectors. Private sector is on certain levels unregulated till now, and there is a diverse landscape way beyond what we have been able to capture even through our PPM interventions, regardless of all the work that has been done. We came across an opportunity. We came across an idea where we saw that the IQVIA report came out, and it said that 169,000 people affected by TB are actually getting like the full courses are being sold at the pharmacies. So we all placed our brains together on what we can do, because there was a tendency from the Ministry of Health to actually literally ban the sale of drugs from private pharmacies and then ask people to get services in the public sector or something like that. We came up with the idea. This was supported by Stop TB Partnerships TB Reach Initiative, maybe one of the project that contributed to the data that Tawfiq was just presenting, that we don't want government to ban the sale of anti-TB treatment. Rather, maybe we can work together with them, come up with a way in which these cases, these people affected by TB, can be notified to the government while they still continue accessing the treatment from where they are preferring to. So we started with the meetings with the Ministry of Health, with the Drug Regulatory Authority, with the Pharmaceutical Association, with the Pharmaceutical Manufacturing Association, so on and so forth. And we came up like, okay, pharmacies can do that. We need a tool to enable them. So we launched an app called eTB, a platform for notifying people with TB through pharmacies. And on an administrative perspective, rather regulatory perspective, notifications was issued by the government that notification of people getting drugs from the pharmacy, getting anti-TB treatment from the pharmacies, is mandatory. And this kind of went on with a regulatory and a mix of enablers approach to get through this. And we saw some awesome results. We piloted this in 4 districts of Punjab province in Pakistan, and we saw that in a year time, we were able to get over 15,000 people affected by TB notified through these pharmacies, which brought the additionality of these districts by 23%, which means that these people who were buying drugs from the pharmacies were actually never being reported to the government through our regular GP model and all, because this was all additional notification over and above what we were already historically getting. This idea was very well taken because of the results and all, and a particular work being funded by Bill and Melinda Gates Foundation in Pakistan kind of took it over with Mercy Corps as private partners, and the Dopasi continues, my organization continues to be an advocacy partner in this. And From the initial 4 districts supported by TB Reach, now this intervention has been scaled up to 57 districts across the country. And we are doing advocacy with the pharmacies, with the drug associations, with the provincial programs to actually expand the similar thing, that we don't put a ban on the sale of the anti-TB treatment. Rather, we encourage the pharmacies to notify people, to keep notifying. Our pilot initially, the Punjab one, was in modern districts. We further wanted to learn on how will the impact be and what are the traditions and the prescribing patterns when we see at a rural district that does not have what do you say, that does not have maybe that access to technology and all. So as a small sort of just a small pilot which we did further in one of the most remotest province of Pakistan, which is Balochistan, in Quetta, we took the same approach, just it was a different province. It was not a modern province or a modern district, and we wanted to see how this thing works there. And to our surprise, what we saw in this particular district was that all the pharmacies which are in can say the city center or near the city center, they don't receive prescriptions. They don't even at times have anti-TB treatments available. They say like, we don't have available because there is no sale. That's why it's not. That means that patients there are actually going to the GPs in the private sector who are the conventional GP, covered by the conventional GP model supported by Global Fund. We were still seeing data from the pharmaceutical manufacturing company and the distributors that was saying that there are sales. We took list of the pharmacies that are still buying anti-TB treatments from the distributors and the pharmaceutical manufacturers. And these were quite out of the town from the central place. And when we reached out to those pharmacies in those areas, they were probably the areas that were not covered by our GP model. And we were able, in I think 4 quarters or 3 quarters, we had an additional notification of around 1,000 people with TB, with around 238 pharmacies engaged. And that again led to a significant additionality. So the key things that come out of it is, yes, as said earlier, we need to go beyond the conventional actors when it comes to PPM, and pharmacies still continue to be a key actor when it comes to PPM. We need to have a friendly model that both has a regulatory approach, but then an enabler approach. Like she just asked, like, were there any applications used in the program? So the pharmacies don't have time to actually fill out the long form. So maybe filling out an application with only a couple of questions, and then our call center actually following up and getting in touch with the patients was something that was doable for the pharmacies. Moving forward, we saw like if there is this one particular sector that we tapped and it resulted in such high yield, maybe there is a need to study the landscape of the private providers in a further detail, and we need to step out of our of the conventional actors that we have been working with. So we initiated, again supported by Stop TB Partnership, on a PPM landscaping study and capacity assessment. We met with the leadership of the CMU, NTP. We engaged parliamentarians, Pakistan Chest Society, Family Physicians Association of Pakistan, Pakistan Pediatric Society, provincial TB control programs, and we did consultations all across the country in all the 4 provinces with all these different actors engaged, be it the Pediatric Association or the Pharmaceutical Association or the Family Physician Association, to really understand who are the ones who are already engaged with the program, who are the ones that are not engaged, but they can be engaged if we extend some kind of a support, or if like people buy and kind of understanding if they know that there is an effective PPM program working in the country, what is hindering them, or what is the key barrier that is not letting them or they don't want to engage with the sort of program. Are the study results, which we are still kind of exploring in further detail. One key thing that came out of it was that per our current GP model, the percentage engaged with NTP through the Global Fund support is 20%, which gives that 80% of the private providers, practicing private providers, and some of them pulmonologists, are not engaged by our current programs. And there are multiple stakeholders that have literally never been tapped before. So we started a further scenario around how can we advocate for potentially increasing this untapped potential that stays there. And in the current scenario of things, how can we actually, like, tomorrow you go to a government, they promptly say, okay, if there are no drugs, we'll start funding drugs. If there is no this, we'll start funding this. However, when it comes to private sector, which has historically, even with 20% engagement of the private sector across the country, giving us over 40% of the case notification, tomorrow, if there are no funds from the donors and the sources, government does not have the ownership, the government does not have, the commitment to actually taking it forward. So we have initiated work on actually developing an advocacy roadmap on how can we advocate for ownership of PPM by the government stakeholders in the country. And then we have initiated some work around community-led monitoring, which we have been doing with the public sector historically, in the private sector as well, to access the patient perspective around it. And then on the advocacy roadmap, we'll be basically accessing the government perspectives. How can we actually go for a sustainable program, sustainable PPM, regardless of the current funding landscape and beyond the historical actors that have been supporting. Thank you so very much.
Thank you, Kinz, for that energetic, most impressive work that you have been carrying out in Pakistan. I'm sure there are a lot of questions, just paucity of the time. Kinz, I would request if you could take up some of the questions on the question answer session. Thanks, Taufik, for answering some of the questions. Now I call upon the last speaker, Ms. Jeane Mallari. She is a licensed nurse and a seasoned public health advocate, over a decade of experience in coordinating and managing the health projects. Currently, she is serving as a project coordinator for the Access TV project under the Philippines Business for Social Progress. Over to you, Jeane.
All right. Thank you. Good evening from my side of the world. And thank you for inviting the Philippines Department of Health in this webinar. I will be presenting on behalf of Ms. Crystal Ann Angeles, who sends her regrets for not being able to join us today. I will be also turning off my camera to help conserve internet bandwidth. All right. Next slide, please. All right. The outline of my presentation. We'll have the rationale, and then the profile of private health providers in the Philippines, and then current government strategies for engagement or initiatives. We also have the success stories and innovations, challenges in engagement, and ways forward and lessons learned. All right, next slide, please. So this figure illustrates the health-seeking behavior among symptomatic, presumptive, and confirmed TB cases based on the 2016 National TB Prevalence Survey. So among those surveyed with TB screening symptoms, only 19% consulted a healthcare worker, 41% took no action, and 40% self-medicated. And of those who consulted a healthcare worker, 67% consulted public facilities, while 30% consulted private providers. So there is really a significant proportion of TB cases going to the private sector. Next slide, please. So this is the Philippines and the private sector profile. This is from the 2024 data. So there are 10,739 facilities identified by the DOH as PMDT, that's referring, notifying, and providing facilities. So these are mix of public and private facilities. And there are 6,346 private registered in Integrated TB Information System, or the ITs, which is a the national data system of the Department of Health for TB. That's referring, providing, only notifying providers. And based on 2024 data, there are 453 private providers engaged in mandatory notification. But I believe we have already thousands of engaged private providers. Next slide, please. So these are the government strategies for engagement. So for policy frameworks and legal mandates, we have the Comprehensive TB Elimination Plan Act, or the TB Law. We also have the Universal Healthcare Act, or the RA 11223. We also have the DOH Administrative Order 2020-0057, which is the guidelines on mandatory TB notification, and Department Memorandum 2023-0071, which is the revised notification of malaria and tuberculosis. And we also have collaboration with the Department of Labor and Employment, and they issued an issuance on TB in the workplace policy. For engagement platforms and partnerships, we have the TB National Coordinating Committee, wherein members include national government agencies such as DOLE, as previously mentioned, PhilHealth, Department of Education, DILG, Department of Interior Local Government, and others. And we also have private organizations such as Philippine Pharmacists Association, Philippine Medical Association, and PhilCat. We also have the Philippine Coalition Against Tuberculosis, and other national civil service organizations. We also have international partners such as WHO, MSF, Stop TB, KNCV, Global Fund, TB Alliance, to name a few. Other than that, we also have the Laboratory Consortium, wherein PhilCat is the secretariat. For the service delivery integration, we are already implementing the integrated delivery of TB services in the private sector. Recently, we piloted, or we inaugurated the IDOTS facility of the Medical City. And then we also have implementation of advanced technologies such as IGRA, ultra-portable chest X-ray, in the private sector. It is not yet in the public sector or in the government, since it is still undergoing HTA approval. And then we also have PhilHealth TB Dots package, which can be availed by the public and private sector. And then for the capacity building and support, we have professional societies as partners, as our partners, and they are invited as resource persons and experts in trainings and in the development. And they're also invited during consultations and in the development of guidelines and policies. And we also have the IT's Lite platform. This is a reporting system for the private sector. And then for the regulation and quality assurance, we have the DOT certification and field health accreditation, and the laboratory EQA. So on this, for these two, the private sector is also covered. Next slide. The next slide shows a specific presentation for PhilCat. So PhilCat is engaged. We are engaging PhilCat as a project implementer. They are the subcontractor of the Access TB project for the private sector engagement. So they have the private sector engagement officer, wherein they engage private doctors or physicians to report, to notify TB cases. And they also have the RX Pass and the incentive scheme. So the RxPass is to address access issues of the private sector to MWRD testing, and they also provide chest X-ray. So for the incentive scheme, this is a recognition of private physicians to private physicians who conform with the NTP standard in notifying, diagnosing, and treatment of patient. So this is piloted or in being implemented as a project of PhilCat. And then as an initiative of as a strategy of PhilCat. So we are also partnering with PhilCat as an organization. So they have been in the TB world for 31 years already, and they are a facilitatory body for national advocacy with the public and private stakeholders. So they are organizing annual PhilCat convention every August, and they are inviting the private sector and the public sector in and present annual NTP updates and innovations being implemented in the country. Next slide, please. The next slide shows about PhilHealth. Wherein PhilHealth is the national health insurance of the country of the Philippines. So Consulta package covers comprehensive primary care services, including consultations, case management, and health education. This covers chest X-ray, also other laboratories and other medications. So per year, a member may benefit 1,700 pesos per year. So public and the private sector can also avail this. And then we also have the outpatient TB Dots package. So currently the benefit is at 7,800 pesos or 137 US dollars from 70 US dollars in 2013 when this was first implemented. And based on the data provided to us by PhilHealth from 2017 to 2023, based on the trends, there is an increasing number of TB Dots package provider by the private sector, and an increasing amount as well in the TB claims. So, based on initial analysis, so increasing number of PhilHealth accredited facilities is due to intensive advocacy of PhilHealth in DOH to these facilities, to these private facilities, and also making reimbursement easier and accessible to them. They are allowed to use private electronic medical records, which is interoperable with the PhilHealth system, making filing of claims easier. And most likely, these private facilities have a PhilHealth point person who will be able to file claims and do follow-ups. Next slide, please. Success stories and innovations. So we have strong partnership with the Philippine Medical Association. So last year they conducted the first TB summit, and then this year just this March, first week of March, they conducted the second TB summit. Participants are PMA members, Philippine Medical Association members from all over the Philippines. And then we have also the participation of the private sector in the TB National Coordinating Committee. And we also have engagement of the medical city as an IDOTS facility. So as an IDOTS facility, they are able to provide full TB services, including DRTB. So the management, the hospital management showed full support, even provided them with its own facility. They have their own consultation area, sputum collection area, and sputum collection area. And we also have partnership with different organizations. So I only highlighted here the partnership with TB Alliance because this is the most recent, and they were able to help us conduct the TRTB training for regional coordinators. So they helped us do training on BPAL-M. And then we have partnership with the PTSI, Philippine Tuberculosis Society Incorporated, and they are one of the recipients of and they are also utilizing ultra portable chest X-ray with AI. Next slide, please. challenges and lessons learned. So one of the challenges of the program is limited funding for PPM technical assistance. So the PPM was supposedly the PPM strategic plan, updated PPM strategic plan was supposedly will be funded by the USAID but however, since the cessation of the support, we were halted with the development. So we are still looking for possible funders to help us develop the PPM sub plan. And then next is high dependence on clinical diagnosis with low access to molecular diagnostics. So that's why PhilCat strategized to implement our XPass. And then decrease in treatment success rate. So that's why they also implemented the incentive scheme. So based on the data provided by PhilCat, initial analysis, the data is improving. So the number of patients tested by MWRD is increasing in the private sector, and there is an improvement in the treatment success rate from the private sector. And as for the lessons learned, strong political commitment is essential. The participation of the private sector in the TB and CC, and making TB as a priority program of the DOH. And it also helps that our Secretary of Health, Secretary Urbosa, is the chair of the Stop TB Partnership. And next is use of innovative technologies is also important to help in case reporting and monitoring, such as the use of IT Slide, IGRA, ultra portable X-ray with AI. And then engagement of professional societies is key. They provide expertise, guidance, and support, and most especially in advocating to their members and their patients. So it is important to have a TB champion from the medical society. And then one of my last slides, ways forward. So one would be the development of the TBPPM strategic plan for 2025-2030. This is a sub-plan of the National TB strategic plan. And then next would be the improvement of the field health package to include MWRDs, DRTB, and then the TB. That would be all. This is the end of my presentation. Thank you.
Thank you, Diana. Your country has shown a way of how to integrate the TB care into the insurance package and how to make it sustainable. We have some questions. Petra, how much time we have? Can we take 5 minutes question and then I can hand it over to you?
Yes, please go ahead.
The one question is predominantly on how do we finance the TBPPM activities? And also when we provide financial incentives to the private practitioners to engage them, how sustainable it is. Tawfiq, if we could just reflect on, from your experience of TB Reach projects, what has been kind of incentives that were provided to private practitioners? And Kinz, it would be good to reflect on what is your advocacy in Pakistan on how to make this PPM more sustainable. We will start with you, Tawfiq.
Thank you, Sri. Yeah, it's a very critical and also timely question considering the recent aid cuts. So we have seen like different private providers, like when we say different, it means like informal private providers are triggered by different incentive mechanism rather than the conventional or like formal private providers. For the formal private providers, it not actually the financial incentive that can kind of engage them because they have good practices. We presume that they have good practice in the private sector. That's why we are engaging them. So for them, access to new diagnostics like the AI-enabled X-ray, Gene Expert, or other newer tools that's coming can be an incentive for them. And also time to time updating them or their students in new guidelines on PPM or even tuberculosis can be some sort of incentive. Sometimes we have seen that they are keen to contribute in academic publications as well. And these sorts of things can attract private providers and bringing them into the National TB Control Program as an expert to provide their feedback also works. And for the informal private providers, sometimes recognition from the National TB Control Program as a qualified or certified TB screener works and can they are attracted by the social recognition receiving from these government bodies. And sometimes, yes, we have seen that different programs also provide financial or a monetary incentive. But yes, the sustainability of that or an alternative to that solution is varies depending on the country context and also with this changing landscape.
Thank you.
Yeah.
I understand. Thanks for emphasizing that it's not always the financial incentives that matter. There are a lot of non-financial incentives that we need to leverage when we engage the private sector. Thanks for bringing that. Kinz, could you please reflect on how do we make this PPM more sustainable? Kinz, can you hear us?
Sorry, I was speaking with my mic muted. Yeah. So what has been done till now is mapping all the providers and mapping all the advocacy outlets, the pharmaceutical associations, be it the family physician association, so on and so forth. And our plan is to engage. We have engaged with one of the provinces, that was the province of Sindh, to actually make the Minister of Health understand the value of PPM and the value. This is not people, this is not like private companies cases. These are people affected by TB in your own country. They are accessing their care from these private outlets. Don't think about the partners. Think about engaging these private providers who are very much our own, and to own them. And they're going towards it. We haven't gotten there yet, but we're still tapping and we're continuing just to get this ownership, just to get this concept around their minds that these providers are your own. These providers are not somebody else's, and this contribution coming from the private sector is basically contributing to the country's what do you call it, countries case notification or everything, and bridging the gaps for us. So that is what we have been doing. One success was getting 2 indicators around TB included in the National Health Support Program of World Bank around TB that got allocated over 7.4 million just in one province. So let's see how it goes. It's a continued fight, and we are all in this together.
Very nice innovations, Kinz. Thanks for sharing. Diana, do you like to reflect on this very important topic on how do you make this PPM sustainable? You have some examples, but do you have any suggestions for other countries?
Yes, in the Philippines, the use of national health insurance is really important. In the Philippines, it has been beneficial for us. We have the the field health package. So as I've mentioned earlier, from in 2013, our field health package is only at 4,000 pesos, and now it has increased to 7,800 pesos. And based also on data from PhilHealth, the private sector providers from the private sector and those who are claiming from the private sector is increasing from 2017 to 2023. So from that PhilHealth benefit claims that they are receiving, they are able to fund their facilities for sustainability. They are no longer they have another source of income or funds other than the ones coming from their facility. So and since we also saw the advantage of having a PhilHealth insurance, we are also pushing for inclusion of the DRTB, drug-resistant TB, in the PhilHealth package, and the TPT, and inclusion of MWRDs in the PhilHealth package. So the private sector will be more enticed to be accredited and to file claims, and for them to be more sustainable in their activities. Thank you.
Thank you, Diana. One follow-up question. Who takes the lead in this kind of advocacy? Is a kind of set of advocates who are doing this, or have you engaged with some private practitioners? How are you pushing this policy changes?
Yeah, we are in close coordination with PhilCat and PhilCat and PhilHealth, which is the organization doing the accreditation and providing claims. So we are in close coordination with them for the advocacy, and it also helps that they are also part of the TB National Coordinating Committee. So through the TB-NCC, we do advocacy, and of course the PMA, the Philippine Medical Association, is also a big help, because they also help in the advocacy through their members. The PMA is the umbrella organization of all doctors in the Philippines. So through them, they are helping us advocating for PhilHealth accreditation and filing claims.
Thank you, Diana. I thank all the experts joining for today's webinar. Very useful, very meaningful, very insightful. Thanks for joining. Thanks for your time. I hand over the floor to Petra. Thank you for giving me this opportunity to both moderate this very interesting webinar. Over to you, Petra.
Yeah, wonderful, wonderful presentations. Really, I know that Monica and Kinz had to drop off because we're really at the time, but I so much appreciate you. All four of you have done a fantastic job in showcasing the importance of why we want to reach those people that are really at the front lines providing the care. And Tawfiq, your overview of all the different projects has shown the impact, as has Monica with the data. And Kinz's vibrant presentation on Pakistan, and Diana, your excellent examples on the policies in the Philippines brings it all together. So Shri, wonderful moderating. I have the honor to present to you quickly. I'll do it quickly because I know everyone has probably I'm going to share with you the photo contest and the winner of today's photo contest. I hope you can see my slide presentation in full screen. So we had fantastic submissions from the field on the photo contest, and thank you so much. We asked specifically for those of you that have engagement with private providers in the field and with communities, and we got many submissions, and our judges selected these 5 images, and I'm quickly going to run through all 5, and then I'll let you know, thanks to all your voting, because everyone voted. We had public voting. So this is a fantastic picture from Kenya with the Conference of Catholic Bishops that are doing a radio program. The engagement of these faith-based leaders is a critical component in Kenya. There are some fantastic facilities in Kenya that are run privately with these faith-based leaders. So for them to be part of the outreach, and I love this leader in action here in the radio program. Wonderful submission. A submission from India where this young girl is in a health camp and receiving information about TB, looking at the pamphlet, showing the health camps and the importance of TB camps. A wonderful picture from Myanmar where TB care and support on mental health and providing of care and support to patients continues even though they're sitting knee-deep in the water. This is a picture from India where a doctor is visiting within the private public scheme. They are visiting a patient and looking at their X-ray and going over their profiles. So And this is the final picture was a picture from Zimbabwe with kids saying, yes, we can end TB, which was submitted to us. So these 5 were selected by the judges as our top 5. And now, drum roll, because I think all of these 5 deserve a lot of accolades. The winner of the picture, thanks to all your votes, and the story is definitely captivating, is our picture from Myanmar. Congratulations, colleagues. Pio Wang Lin, you did a fantastic job. A beautiful image. Thank you for sharing it with us. And it showcases that, honestly, our frontline care workers, private care workers, you are the most resilient to continue working in any circumstances that we can see. So thank you so much for sharing your images and for sharing your votes. Really appreciate it. And with that, I'm going to close the webinar for today, wishing everyone a wonderful rest of the Friday. Appreciate all the work you do to engage all providers, because we need to reach everyone who is affected by TB. The pictures, the report, the presentations, everything will be on the Learning Network. We will post it in the upcoming days, and you will see it through either news messages on social media or check in with us. We're happy to send things to you directly if you're looking for something. Looking forward to being in touch with the next webinar or any discussion. Reach out to us if you have ideas. And as always, have a fantastic rest of the day and the rest of the weekend. And thank you to our speakers and our panel for a great job. Bye-bye, everyone. Thank you so much.
Bye-bye. Thank you.
Thank you also. Bye-bye.
Bye.
Bye.